Great.
Thank you very much. It's a pleasure to be here. So I'm going to be speaking primarily about fracture dislocations of the elbow today. And there are just a few key points that I'd really like to make. These are highly complex injuries, and we can spend many hours discussing some nuances of how to treat these different types of injuries. But some of the most important concepts, I think, are that, number one, it's the ulnohumeral articulation that is exceedingly important in treating these. Number two, if you do have something that you consider to be a simple elbow dislocation, but it seems to continue to be very unstable after reduction, then you should be considering immediately that there may be something else going on, like a fracture. Anatomical restoration of the proximal ulna is going to be the key to maintaining elbow stability in this type of an injury. And also just beware of resecting the radial head in the early phase of treatment of these injuries. So Sean O'Driscoll and David Ring and Graham King and a number of others have gone to great lengths to demonstrate to us how the elbow maintains stability. And Sean O'Driscoll, back about 10 years ago, described primary and secondary stabilizers of the elbow. And I think this is important. If we look at the primary stabilizers, the ulnohumeral articulation is the main bony stabilizer of the elbow joint. And then you have the medial collateral and the lateral ulnar collateral ligaments. Now, that being said, you may say, well, if we can restore the primary articulation, for example, by repairing a coronoid fracture, then what difference does it make if we have a radial head in place? Because the radial head is only a secondary stabilizer. Well, that is true in the setting of an intact elbow. But in the setting of a fractured elbow, the secondary stabilizers can become very important, and the radial head is of very high importance in this case. So if we look at something that we might consider a standard elbow dislocation, remember, failure to maintain reduction can imply a number of different things. It could just imply that the soft tissues are so severely injured that it's just going to be unstable without a surgical repair. However, something to consider also is that there's a bony injury, and perhaps incarcerated fragments may reside within the joint, and this can keep the elbow from staying reduced. So a CT scan sometimes can be helpful if you're having difficulty delineating the anatomy. So in this case, for example, this is a patient who had what appeared to be a simple elbow dislocation, but it was rather unstable after reduction. And a CT scan revealed that there was indeed an incarcerated bony segment inside the joint, and this patient did benefit from operative repair. So we talk about complex elbow instability. This is elbow instability where there's a dislocation associated with a fracture. And four main types really have been described, and there are many variations on these themes. But for the most part, this is what we talk about when we talk about fracture dislocations of the elbow. So the four types are the terrible triad, the transolecranon fracture dislocation, the Monteja variant injury, and then posterior medial varus fracture dislocations. And all of these really require an operative intervention to achieve a better outcome. And I'm going to go through all four of these in sequence. So the terrible triad injury was so named because it has historically abysmal results with non-operative treatment or with inappropriate operative treatment. And the injury complex involves three things. There's generally a radial head fracture, there's a coronoid fracture, and then there's an elbow dislocation associated with these. Treatment principles basically focus on repair of parts, if not all of the injuries. So repair of the coronoid fracture, or in the setting of a small coronoid fracture, repair of the anterior capsular attachment is important. Repair or replacement of the radial head, and repair of the lateral collateral ligament is generally accomplished. We rarely say never in orthopedic surgery, but one thing that we've found, and especially David Ring and Jesse Jupiter's group have really gone to great lengths to show that ignoring small coronoid fractures can be very detrimental to the outcome of these injuries. And also resection of the radial head in the setting of a terrible triad injury without replacing it is a bad move early on. Normally, and luckily, the medial collateral ligament does not usually require operative repair, although sometimes repair of it is beneficial if the elbow remains unstable after repairing the lateral side. And the tactic that's usually utilized for this is generally a Coker approach to the elbow. This can be accessed directly posterior. The lateral collateral ligament is most often avulsed from the lateral epicondyle, and you stare at a bare surface of the lateral epicondyle. And then if you're going to be resecting the radial head, this is a good time to do it because it can improve your visualization of the coronoid fracture. So the coronoid fracture is then repaired, or the anterior capsular attachment is repaired if the coronoid piece is too small. David Ring has shown that anatomical reduction of the coronoid is not necessary for good outcomes. However, repair of the coronoid or of the capsular attachment is necessary. And you can repair this any number of ways. There's been described a suture technique, also screws if the coronoid fracture is large enough to accommodate screws, and for very large coronoid fractures, a plating technique is acceptable. Once this is accomplished, you can complete your repair of the radial head or complete the replacement of the radial head and then repair the lateral collateral ligament during closure. So these still do have complications even when properly executed. Redislocation hopefully is not the complication that happens when these injuries are addressed properly, but redislocation is more common when you fail to address the coronoid fracture fragments or when you excise the radial head without replacement. So stiffness is very common after these injuries, and early aggressive active and active assisted range of motion exercises can help prevent this. There is some evidence that passive range of motion early can actually increase the degree of stiffness and heterotopic ossification that may occur. Moving on, we move to a transolecranon fracture dislocation. Now, it's important to recognize these. These are not simple olecranon fractures. These are not generally amenable to tension band wiring. They have high rates of failure with just simple tension band treatment. Really what this is an olecranon fracture that's associated with an anterior dislocation of the elbow. One of the hallmarks of this, however, is that the proximal radial ulnar joint is intact. And what's nice is that the ligaments may be intact as well. So it may be that all we need to do is repair the olecranon. So the tactic for repair is generally an extensile posterior exposure, where you raise full thickness cutaneous flaps. Sometimes there are radial head fractures that are associated, and you can access these through the Coker interval through your same incision. Coronoid fractures, if you're lucky, can actually be addressed directly through the olecranon fracture line, and it's difficult to visualize them sometimes, but you can often get some visualization of the fracture bed. Anatomical reduction of the olecranon is crucial, and usually plate and screw constructs are required for sufficient strength to be able to maintain your reconstruction. And again, normally the ligaments are relatively spared, so this is an example of a transolecranon fracture dislocation. And the repair simply concentrated on the ulna in this case. But here, if you notice, multiple screws with a plate placed posteriorly was what was utilized for fixation of this fracture. Now, the Monteja variant fracture dislocation is a different type of animal. So most often, these are posterior dislocations of the elbow with associated proximal ulna and olecranon fractures. And very often there are associated radial head fractures. The key to this is that you treat it the way you would treat a Monteja injury of the forearm, where anatomical reduction of the ulna is the key to reduction and maintenance of stability of the elbow. So again, anatomical reduction of the ulna, this is the key. And so this is an example of a patient who sustained a Monteja variant fracture dislocation. You'll notice that there's a coronoid fracture, and the radial head is fractured and is dislocated out the posterior aspect of the radiocapitellar joint. And this repair was accomplished just of the ulna, a highly complex ulna fracture which was reconstructed anatomically, which maintained good reduction of the radiocapitellar joint. Finally, more recently described by David Ring and colleagues is the varus posterior medial fracture dislocation. Failure to recognize this injury, this can appear very innocuous, but it is a very important injury to recognize, can result in poor outcomes, including early arthrosis. They're very easy to overlook because generally the coronoid fractures can be somewhat small in these, and radiographs may not be of high quality. So this is an example of an elbow that sustained one of these injuries, relatively innocuous looking. There is the coronoid fracture there. It's important not to miss this. This is that same elbow with an anteroposterior projection where you can see the coronoid fracture medially. So this patient did have an unstable elbow, and unfortunately we did not save images of the instability, so I borrowed a slide from one of David Ring's talks, where if you do a stress examination of these elbows in the operating room, you'll see how clearly unstable they are, with disruption of the lateral collateral ligament often accompanying the injury. And you can see the varus stress that creates opening on the lateral side. This was repaired with a plate and screw construct, along with a repair of the lateral collateral ligament through bone tunnels. So in summary, elbow stability is most reliant on the ulnar-humeral articulation. Consider the possibility of fracture in a simple elbow dislocation that is highly unstable. Anatomical reduction of the proximal ulna is really the key to maintaining elbow stability. And beware, radial head resection early and acutely during these repairs may doom your reconstruction. Thank you very much.